like to get to our next speaker immediately, if not sooner. I'm not sure at this point that Dr. Mickey Barber needs another introduction, but I will just say that she's the CMO and CEO of Synergetics Medical Institute in Charleston, South Carolina. My pleasure once again to introduce Dr. Mickey Barber.
Let me see if I get the things. Where's
The pointer should be... It's right there.
Okay. Thanks. Well, good morning again. And this age management medical stuff really works because I just found out I'm older than those trees. I think I look pretty good for that. I'm going to talk about medical myths and how we can bust them. And I've always been interested in what doctors say that we believe are true, facts that we then pass on to our patients. So I decided to take on this topic for today's talk. This is me biting off more than I could chew. I originally was going to talk about 10 medical myths, and when I got into my research for that, I discovered that there is a lot of information, and it became more important to just focus on 3 and to point out a few more that you can research, and most importantly, how to be more discerning when learning information and passing it on to our patients so that we don't pass on medical myths. So we're mythbusters. What's the definition of a myth? It's a traditional or legendary story, usually concerning a hero or event, with or without basis of fact. Now, surely we don't do that in medicine, but I will propose that perhaps we do. So the objectives of my talk today is to discuss how medical myths influence doctors and their patients, and to discuss our role as physicians and health professionals to curtail medical myths, and to detail common, many times controversial medical myths, and maybe most importantly, to discuss how medical myths become our beliefs. The 3 that I'm going to talk about today, one is what I like to do every morning, which is have a cup of coffee. And I find so many patients come in and they're so proud of themselves when they say to me, well, I only drink 1 cup of coffee a day. So I'm going to talk a little bit about that and if they're indeed doing the right thing based on their doctor's orders. The next thing that I discovered when I began my age management medical practice was that when I started to have patients eat more fats and eggs in particular, that their cholesterol levels improved. So we're going to talk about the exact truth about saturated fat and cardiovascular disease. And the last myth is probably the myth that has had the most impact, I would say, on women's health in this country. And it's simple. HRT, hormone replacement therapy, causes breast cancer. I also want to get you thinking about, when you leave here today, some other myths that you may be propagating. Homocysteine and cardiovascular disease, prostate cancer and testosterone, interval training and heart disease, and statins for cardiovascular disease prevention in low-risk patients. I first want to talk about some sexual myths, just to get things started on the right track here this morning. Myth number 1, men enjoy sex more than women. Now this is the new form of CPR that's being propagated by the American Heart Association. So myth number 1, men enjoy sex more than women. Research has shown that if you're a man and you believe this, then the truth is that women maybe just don't enjoy sex with you. So, and you see my source at the bottom are 10,000 women. So how do myths become what we preach? Well, there are many ways. First, the media. Second would be the PDR, or the physician's desk reference. Journals and abstracts, governmental agencies, pharmaceutical companies, article bias, inadequate investigation, skimming the abstracts, and inadequate due diligence by us, the physicians. Let's start with the first one, caffeine kills. I'm sure you know that coffee is one of the most widely consumed beverages in the United States and globally, and that coffee drinking is not generally considered a healthy lifestyle choice by most doctors because it contains caffeine. In fact, think about what kind of advice you give your patients. Coffee is bad for you. Coffee causes cancer. Coffee is bad for your cholesterol. Coffee is bad for your heart. Coffee is bad. Or coffee is good, depending on which literature and which day of the week it is. Well, let's talk about coffee and caffeine and what is really in there. So caffeine is a naturally occurring plant alkaloid. It's found in coffee, tea, cocoa. It's an additive in many drinks. It belongs to a group of purine-based compounds or methylxanthines. It also contains what are called phenolic and compounds and lignans. The phenolic compounds, if you look here, have some interesting qualities. They're antioxidant in activity. They can actually protect mammalian cells from genotoxins, and they may inhibit cell replication enzymes and prevent cancer growth through anti-estrogenic pathways or mitochondrial toxicity. The lignans can be converted to enterolactone and enterodiol, and those are phytoestrogens. The lignans also have anti-estrogenic properties and can potentially reduce the risk of certain cancers. Doesn't sound too bad for us yet. Coffee contains more than 1,000 compounds that may affect the risk of death. It's rich in sources of antioxidants and bioactive compounds. It contains B3, magnesium, and potassium. And some studies have showed an inverse association between coffee consumption and serum biomarkers for inflammation and insulin resistance. Some of the studies came out many years ago that really gave coffee a bad name. And the question is, what were the limitations of those studies? Well, really, smoking cigarettes seem to be the strongest confounder in those studies. And studies in the past did not take into account the connections between drinking coffee and smoking cigarettes. It also did not take into account that individuals metabolize caffeine differently. In fact, current research suggests that there is a genetic variability in how individuals metabolize coffee and may or may not affect sleep and the heart. These prior studies also did not consider the method of coffee preparation, which you'll see in a few minutes is very important. The method of preparation in several studies has been shown to be extremely important. Coffee that is boiled actually will cause a significant increase in LDL and a significant increase in homocysteine, whereas filtering the coffee reduces the cholesterol-raising substances. And in fact, espresso has that same positive effect. A study done with NIH and AARP in 2000 and published in New England Journal of Medicine in 2012 looked at a very large group in a prospective study, 229,000 participants. The results, when they looked at their caffeine intake, significant inverse associations of coffee consumption with death from all causes, specifically heart disease, respiratory disease, stroke, injuries, and diabetes. There was a modest inverse association between coffee drinking and total mortality in both sexes. This is looking at that same data, and what you really need to look at here is coffee as a risk, which is on one side of the graph, and coffee as being protective on the other side. And you can see that there are many more dots in the coffee being protected side compared to heart disease, cancer, stroke, injuries, diabetes, etc. What about if you drink too much coffee? Does that look like anybody out there? 2 or more cups of coffee a day can increase the risk of heart disease in people with specific genetic mutation that slows the breakdown of coffee. Let's go on to another myth. Sex myth number 2. You can judge the size of a man's package by the size of his feet. Well, meta-analysis of several studies shows that there's no relationship between the size of the man's feet and the size of his genital organs. So I want you to know that 10,000 women agree. What about heart disease and coffee? Well, an analysis in 2008, two different ones, one a recent one done in 2012 and one in 2008. The more recent one, overall coffee consumption was not associated with significant increase in coronary artery disease. And that was especially when looking at the prospective studies. Another meta-analysis, 21 prospective cohort studies showed that drinking 1 to 4 cups of coffee per day was associated with a lower risk of coronary artery disease. Research has found that acute ingestion of caffeine in the form of a 200 milligram capsule actually increases flow-mediated dilation of the coronary vessels and decreases C-reactive protein in subjects who have or do not have coronary artery disease. That was published last year in the American Journal of Cardiology. What about people and myocardial infarctions? The incidence was 1.4 times higher in men who drank boiled coffee versus men, that should say, who drank filtered coffee. And that risk was even higher for women. At least one study showed inverse association between coffee consumption and mortality in the first 90 days after infarction. Now, my dad had 4 heart attacks before he passed away. And every time he had a heart attack, they told him not to drink coffee after his heart attack. Moderate coffee consumption was not associated with coronary vascular disease or events in post-MI patients. What about cancer and coffee? This study and review in 2011 found significant inverse association between caffeine intake and breast cancer. And this was particularly in women who were positive, ER/PR positive. In fact, recent caffeine intake analysis before the diagnosis of breast cancer showed no association with caffeine consumption and no significant association when observed the difference between coffee intake and breast cancer. A large cohort of women found no substantial association between caffeine or decaffeinated coffee and tea consumption and risk of breast cancer during 24 years of follow-up. So there's really, in this study, no evidence of an effect from either recent or long-term consumption. In fact, caffeine was associated with a lower risk of postmenopausal breast cancer versus premenopausal breast cancer and was stronger in those that were ER/PR positive. Another study showed that women who were BRCA1 or BRCA2 positive and consumed 6 or more cups of coffee per day, 6 or more, had a statistically significant reduction in breast cancer risk. That's compared to women who were carriers and did not drink coffee. What is that about? Well, caffeine is a very important lifestyle factor associated with increased plasma 2-hydroxyestrogen and 16-alpha-hydroxyestrogen ratio. And many studies have shown that high levels of 2-hydroxyestrogen to 16-alpha-hydroxy is associated with a lower risk of breast cancer. Why does that happen? It is thought that these metabolites are processed in the liver, and that cytochrome P450 is important for this, and that caffeine appears to be an inducer of that particular enzyme activity in the liver. So once again, caffeine may be good for you. A study in 2011 concluded there appears to be no association with breast, pancreatic, kidney, ovarian, prostate, or gastric cancer and caffeine. Risk of bladder cancer appears to be associated with a very heavy coffee consumption in some populations and among men, particularly men who are smokers. What are the mechanisms that coffee consumption might exert an anti-carcinogenic and anti-inflammatory effect in some organs? Well, there are several. One, reduction in cholesterol and bile acids in the colon. 2, increased colonic motility, moving things through quickly. Cafestol and Kwal, which are both active in the caffeine oil that decrease mutagenesis and tumorigenesis. Diterpenes, which are found in coffee, which reduce the genotoxicity of carcinogens. Caffeic acid and other antioxidants, again affecting DNA methylation. One study concluded that consumption of coffee at least 1 cup per day was associated with a 3% reduced risk of cancer. All in all, our meta-analysis, including 40 prospective cohort studies, confirmed that coffee drinking has no harmful effect. Instead, coffee consumption is inversely associated with the risk of bladder, breast, buccal, pharynx, colorectal, endometrial, esophageal, hepatocellular, leukemia, pancreas, and prostate cancers. Yay! Aren't we excited about that? Caffeine itself appears to be protective by affecting cell cycle, proliferation, and apoptosis. The average penis is 8 inches. Retrospective analysis reveals the average size of a penis is 6 inches or 15 centimeters, if that makes you feel better. Those same 10,000 women helping us out. Now, this is a myth that we all propagate every day, and that is fat that we eat causes heart disease. I like this cartoon. I eat cheap, greasy food so I can save for my cardiologist bills in the future. The question is, are we feeding our patients the wrong information? Well, conventional wisdom suggests that high consumption of saturated fat and cholesterol leads to an increased blood cholesterol, especially LDL, and thereby increases the risk for coronary artery disease and cardiac disease. The findings that have been in the literature were really based on epidemiologic studies with conclusions rather than statistical correlations. Thus, many of us have been fooled into believing that a statistical correlation is proof of a causal relationship. The USDA and the USDHHS and IOM, all of those governmental agencies that tell us what to do, the recommendation in 2010 was consume less than 10% of calories from saturated fat by replacing them with monounsaturated and polyunsaturated fats. And keep the intake of saturated fats as low as possible while consuming a nutritionally equal diet. There is a lot of criticism of those recommendations. The dietary guidelines published in 2012 have been criticized by several authors for encompassing an incomplete body of relevant science and inadequately representing and summarizing the science on saturated fat in relationship to heart disease. In fact, multiple studies found no association between saturated fat and coronary deaths. According to several authors, results and conclusions about saturated fat and heart disease from leading advisory committees do not necessarily reflect the available scientific literature. Don't you love it when the government gets involved? It's great. Looking at pooled analysis of 11 cohort studies included only one article examining the direct relationship between saturated fat and heart disease. None of the reports of the USDA research findings considered the effect of LDL cholesterol and saturated fat. And meta-analysis of 61 prospective studies found the ratio of total to HDL to be the strongest predictor of ischemic heart disease. The agency recommendations were based on 60 controlled trials that related dietary fat intake to serum cholesterol levels. They stated that consumption of saturated fat increases the levels of LDL, thus concluding that saturated fat increases the risk of heart disease. Concluding. They did not consider HDL or any other inflammatory factors. These findings have led to worldwide recommendations to decrease the consumption of saturated fat. If you look at this particular table, It looks at these agencies and their recommendations, and if you can take the time perhaps later, I do have some jump drives of my slides if some people want them, because these are different than what was in the syllabus. You'll see that many of the prospective studies, in fact, and systematic reviews were ignored in the government recommendations. At least 3 systemic reviews of prospective studies were published examining the direct relationship between saturated fat and heart disease, and did not conclude that changes in saturated fat would change the risk of heart disease. Our results emphasize the risk of relying on cholesterol alone as a marker for coronary artery disease risk. None of these reviews were included, of these prospective reviews were included in the governmental agency's reports or recommendations. The USDA ignored the effects found by their own results, which stated the U.S. reports misrepresented their own results. They significantly increased risks were found only in 2 of the 9 articles included in the results. So they looked at 9 articles, and only 2 of them showed a correlation with heart disease and saturated fat. None of the investigators from the reviews included in this article concluded that changes in saturated fat would change the risk of heart disease. Now remember the routine. You're the good cholesterol, and I'm the bad. They're kind of cute little guys. The American Heart Association recommends that the healthy adults limit their dietary cholesterol intake to 300 milligrams a day. And a large egg contains 210 milligrams of cholesterol. The AHA rationale is in conflict with a growing body of scientific literature. Observational epidemiologic studies that use simple regression analysis indicated a positive relationship between dietary cholesterol and coronary artery disease risk. Results of multiple regression analysis tended to show no significant association. So observational versus regression analysis, big difference in what they've found. The DART study, which was done in 2003 and published in Circulation, either recommended to reduce fat intake to 30%, eat 2 portions of fatty fish weekly, or increase fiber to 18 grams. After 2 years, advice on fat intake and fiber intake appeared to have no effect on mortality or cardiac events. Those randomized to receive advice to eat more fish did have improved survival. And this is looking at the data from that study. And if you look at the intervention and its effect on cardiovascular events and mortality versus the control group, you see that there was not a significant improvement in those variables with intervention through saturated fat and fiber. Well, what's the exact truth about fat and heart disease, particularly with eggs? Now, you know, eggs got the bad name because in the 40s, a study was done where they fed eggs to high fats to chickens, and they found that in the chickens the cholesterol increased, and from that it kind of went down this path where eggs are bad. Now, the Cochrane collaboration that looked at saturated fat in particular made a very weak recommendation. This review suggests that modified fat intake or modified and reduced fat intake are protective against combined cardiovascular events, but no clear effects of these interventions at all on total or cardiovascular mortality. This is when eggs go bad. Cute guy. So a prospective cohort of 21,000 patients in 2011, our data suggests that egg consumption up to 6 a week has no major effect on the risk of heart disease and mortality, and that consumption of 7 a week is associated with a modest increased risk. And this was in looking at 20,000 male physicians. Now, there is a subgroup among male physicians with diabetes. Any egg consumption seemed to be associated with increased risk of all-cause mortality and suggests evidence for an increased risk of MI or stroke. In another study, we did not find significant positive association between egg consumption and increased risk of mortality from heart disease or stroke in the U.S. population. These results corroborate the findings of previous studies. The Harvard egg study. I like this. I always pictured the eggheads studying eggs. I think it's a good, that's what it was called, the Harvard egg study. Medical community and general public, have been concerned about egg use and high serum cholesterol. It is now acknowledged that the original studies purporting to show a linear relationship between cholesterol intake and coronary artery disease may have contained fundamental study design flaws, including conflated cholesterol and saturated fat consumptions, and inaccurately assessed actual dietary intake of fats. The overall finding was no overall association between egg consumption and the risk of heart disease and stroke. This is looking at the data from the Harvard egg study. The conclusion, the small adverse effect of cholesterol in an egg on plasma LDL levels is counterbalanced by the potential benefits on high density lipoprotein, triglycerides, and other nutrients, including antioxidants, folate, and B vitamins, and unsaturated fats. Another study, 9,000 patients, lack of relationship between consumption of 6 or more eggs per week and stroke, coronary artery disease, and mortality. And in fact, they concluded that eggs may be the preferred food item in a carbohydrate-reduced diet. Well, what about cheese? Who moved my cheese? Well, in this particular study, 120,000 patients followed for 10 years found no association with cheese intake and the risk of ischemic heart disease. And looking at this graph here, so the black block in the middle there is cheese, the white is the control group, and the gray is subjects that ate butter. And looking at total cholesterol, HDL, and LDL, you see that the cheese eaters actually had a benefit and was more healthy than the consumption of butter. In fact, cheese lowers LDL cholesterol when compared to butter intake of equal fat content and does not increase LDL. So I would propose regarding heart disease that no dietary recommendation should be made without considering their effect on thrombogenic factors, inflammatory markers, and lipid subgroups. And does the picture change if the effects on HDL, insulin, and ApoB are taken into account? Myth number 4, men think about sex every 7 seconds. Well, an independent analysis showed that if men think about sex 8 times a minute during a football game, then that changes what the sport is about entirely. So how do these myths become our reality? Well, first there's literature bias, statistical misrepresentation, press releases become the source of medical journalism, media spin, and the governmental agency recommendations. Let me talk a little bit about this because you need to be aware of how the information gets out there to your patients and then to you. Press releases are a way that medical information is given to the journalistic industry through pharmaceutical industries, academic medical centers, and medical journals. An independent news rating website concluded that up to 1/3 of health news stories are based solely on a press release. And many press releases omit key facts and fail to acknowledge important limitations. A review that was done in 2012 and looked at all of these major medical journals and 100 original research articles compared abstracts, the articles, and press releases for quality of the newspaper coverage. Compared to the original articles, abstracts and press releases were high in respect to one basic study fact, and so the study size, they were pretty accurate. 94% of abstracts had the appropriate study size information, 88% of press releases. But the quality was low for mentioning or quantifying harms of intervention. So 43% of abstracts, 35% press releases actually mentioned any harms of intervention. Main results showing absolute risk, which is the most important thing. Only 50% of abstracts and 34% of press releases actually quantified absolute risk. And the limitations of the research, only 71% of abstracts and a horrible 40% of press releases talked about the limitations of the research. We found that newspaper stories reporting on medical research frequently failed to quantify the main results with absolute numbers and failed to note harms of innovation, study limitations, or study facts consistent with previous investigations. Disappointingly, medical journal abstract also lacked this information. The conclusion was high-quality press releases issued by medical journals seem to make the quality of associated stories better, whereas low-quality press releases make them worse. No big surprise, but that is what the media is actually relying on, which is why you get a phone call every other day from patients regarding what is on TV. The Annals of Internal Medicine in 2009 selected the 10 highest ranked academic medical centers in the country. They looked at press releases from those medical centers, particularly in human research. Only 77% provided the study size, 66 quantified the main finding, and only 47% used an absolute number. Looking again at these academic press releases, only 17% promoted published studies, 40% were inherently limited, and in the laboratory studies, 66 claimed relevance to health, human health, without any real caveats to back that up. By issuing fewer and better press releases, academic centers could help reduce the chance that journalists and the public are misled about the importance of medical research. I want to talk a little bit about politics, about spin. My goal is to eliminate poverty from now on. We'll call it negative wealth. There is spin in the media and spin in medical journals. Trial results can be distorted by the use of spin, which is defined as specific reporting strategies, intentional or unintentional, emphasizing the beneficial effect of experimental treatment. This occurs from misrepresentation of statistics, data abstraction, and misrepresentation of results. This is a great article to get your hands on, Misrepresentation of Randomized Controlled Trials. A study by the British Medical Journal in 2012 stated that newspaper stories reporting on medical journal research frequently fail to quantify the main results with absolute numbers. The factors associated with spin in the news are specialty journals. So a specialty journal has more spin, a small sample size, spin in the abstract, and spin in the press release. I love this chart here. This is looking at spin, which is the dark blue, versus no spin, and how it becomes propagated in the media. So if an abstract is about 50-50 or whatever that is, spin, then that spin is picked up in the press release and is continued to be propagated in the news. So it starts way back with the researchers themselves and the institutions and journals who put out the information. These are all the different types of spin. I'm not going to go into it now, but just basically kind of taking the information and not emphasizing what is statistically significant in those articles. Researchers at the University of California, again, 5 major medical journals, and found that the majority of trials only report relative risk reduction and do not talk about absolute risk reduction. Back on spin, our review of the literature showed that in the majority of cases, only the most favorable statistic, the relative risk, was used when reporting results of studies. It's kind of scary, isn't it? Most of us expect that our medical journals will provide complete reporting of all information aspects of research on a new treatment. Without more comparative data, readers may be basing their decisions to use a new treatment on incomplete information. The WHI study, for those of you that are new to this field, the Women's Health Initiative, has really, in my opinion, scared women and their doctors to death. And how did this happen? Well, the first step was a misleading press release that was released on July 2nd, 2012, that said that the trial of estrogen plus progestin has been stopped due to increased breast cancer risk and lack of overall benefit. The New York Times then picked that up and said, study is halted over the rise seen in cancer risk. The response from the director of the study said, the cardiovascular and cancer risk of estrogen plus progestin outweigh any benefits, with an increase, a 26% increase in breast cancer risk. Too high a price to pay, even if there was some health benefit. These risks outweigh the benefits of fewer hip fractures. The press release failed to mention that the study was only focused on older postmenopausal women who, in general, would probably not have been started on hormone therapy to begin with. This is a copy of the press release, and I don't think you can read it. What basically happened is that they sent out the press release, and they invited journalists to meet in a hotel room like this to discuss the press release before it had actually even, the article had been reviewed by scientific peers. The information was leaked a week prior to publication to newspapers and before the vast majority of clinicians and peers in science had the opportunity to read the paper and put its findings into context. Therefore, the damage was done, and women and their doctors everywhere remained scared to death. My phone rang off the hook. Medical articles on HRT and breast cancer risk generally emphasize relative risk, and relative risk only is meaningful when the absolute risk is high. An absolute risk is really the incidence or the number of events that occur in a given population. An example that you could put in perspective, the risk of dying in an airplane crash is 1 in 10 million. Now, if you take 5 flights, then you could say that my risk is increased to 5 in 10 million, or a 500% increase in relative risk. This is an example of high relative risk where the absolute and excess risk are really meaningless. The use of relative risk statistics overemphasizes actual risk, so you have to pay attention to this. This journal that is put out by the International Menopause Society, really since January of 2012, every single publication they put out has been dispelling the myth of the WHI study. So you should get your hands on these journals if you haven't already. The Endocrine Society recommends that interpretation of the WHI and observational studies should assess excess risk rather than relative, because that relative was actually stated as a 26% increase when the actual risk was 4 cases per 1,000 over a 5-year period, which is nowhere near 26%. The evidence did not support that estrogen replacement therapy or HRT are associated with an increased risk of breast cancer. So how do women feel about these risks? What has happened to us since this came out in 2002? Well, regardless, in one study, of whether women used HRT or not, they overemphasized their actual risk for uterine and breast cancer. And in fact, the findings suggest that continuing efforts have to happen to help women to understand the benefits and risks of HRT. And I would suggest that continuing efforts to educate physicians needs to happen as well. What about side effects? Side effects from HRT. And this woman, she's so confused. She thinks, she's losing her hearing over it. What about breast cancer and heart disease? Again, when they looked at very highly educated women, median age of 50, 52% of the women thought their risk of developing breast cancer by the age of 70 was 10%, and 73% of women estimated their risk of heart disease to be only 1%, which is actually the opposite, which is very sad. 61% of women between 45 and 64 were more afraid of cancer, particularly breast cancer, than heart disease. And heart disease remains the leading cause of death in women in this country. The impact of HRT on breast cancer risk remains relatively low, but much emphasis has been placed on this issue in the lay and scientific literature. In a study done in 2005, they found that no or little increased risk with estrogens used alone or combined with progesterone. The excess in risk received significance when estrogens were combined with synthetic progestins and not microionized progesterone. Is HRT contraindicated in women with a history of breast cancer? Most of us would say yes. Are you really giving your patients all the information? Looking at 25 women participants in this small study, And these are the different stages of cancer. The findings were 3 of the 25 patients had recurrence, so overall survival in this group was 94%. Looking at another group, 319 patients on ERT after breast cancer, comparable tumor size, etc. Estrogen replacement therapy does not increase breast cancer events in this subset of patients previously treated for localized breast cancer. 41 patients, no adverse effects seen in this study in women with breast cancer as a result of hormone replacement therapy. 2,700 women participants. This suggests that HRT after breast cancer has no adverse impact on recurrence and mortality in women with breast cancer. On reviewing the bibliography in the PDR, even though there's a warning for the use of estrogen and its risk of breast cancer in women that have had breast cancer, there is actually no data in the PDR that supports that recommendation. This is looking at several of the studies that have been published, small ones, prospective case controls, and women who have breast cancer using hormone replacement therapy, and showing that it actually does not seem to be increasing their risk of recurrence. 6 prospective randomized studies noted that response rates and duration were similar when comparing tamoxifen and estrogen replacement therapy. In 3 of the studies, women who took estrogen had a considerably longer survival than those who took tamoxifen. Dr. Kreisman, who, interestingly enough, is in Charleston at the Medical University of South Carolina. He's a gynecologic oncologist and is a big wig in ACOG. I went to his office to meet with him after I read several of his articles. He says it would appear from the data that ERT and HRT in the patient who has had breast cancer does not appear to be detrimental. In fact, some of the larger studies found significantly fewer recurrences, breast cancer deaths, and total mortality in hormone users compared to matched controls. There is, according to ACOG now in 2012, there is no conclusive data to indicate an increased risk of recurrent breast cancer in postmenopausal women using HRT. That is a very significant impact statement that has come out by ACOG this year. What are some other myths that I invite you to consider and investigate and see if what you're saying is indeed truth or fiction? Does prostate therapy cause, does testosterone therapy cause prostate cancer? I've given you some articles, and there are many more out there that you can be using. What about patients that have had heart disease? You know, are we pushing them too much with high-intensity interval training? Should they just be walking on the treadmill like it has been sort of historically cardiac rehab? What about statins? They've been used for years now, and just treating a high cholesterol in patients that do not have a significant risk of heart disease. Does it really prevent them from having coronary events? There are many articles and collaborations out there on this topic. What about homocysteine? Are we really doing anything when we treat homocysteines for prevention of heart disease? I ask you to review the literature. What is our responsibility when communicating with our patients? Well, if patients are to make decisions based on risk, they must be given accurate information by their clinicians. When there's been direct observation of physician-patient communication, it's shown that discussions of risk and benefits are infrequent. Now, that's either because we don't have time or we don't really know the risks and benefits. Neither of those, in my opinion, are acceptable explanations. Well, how do we avoid spreading medical myths? Well, first of all, don't take their word for it. Journals and medical institutions release press releases for media coverage, not for science. Governmental agencies have their own agenda and their own bias, and they have their own deadlines. The 2012 Health Task Force just put out another recommendation about ERT and breast cancer and didn't even review the most recent studies that have come out. So being under, some sort of a deadline influences that as well. Read the articles yourself, not just the abstract, not just the conclusion, but read the articles. And read with discrimination and skepticism. Consider the bias of the article and the authors of, and please brush up on your statistics. Really understand what relative risk, what absolute risk, what meta-analysis, what a randomized study. Get there. There's the book, I think it's Biostatistics for Dummies or something. I mean, you can order on Amazon. It's worth getting. It's a very small book, and it can help you, to interpret the articles with more discernment and discrimination. And the last sex myth, masturbation causes blindness. Randomized controlled trials show if this were actually true, then no one in this entire room is reading at this very moment. So I ask that you avoid spreading medical myths. If something smells fishy, it's probably fishy. And if it seems too good to be true, it probably is. And most importantly, follow your instincts. If something comes out in the media or in a journal and it just doesn't make sense to you, if it doesn't sit well with your gut's probably right. And if you look into it a bit more, then you will find that you can stop spreading medical myths. So thank you very much for your attention, and I hope you'll bust some myths.